This video is part 2 in our nerve entrapment series, where I'm going to be covering specifically the greater occipital nerve, the function of it, where it gets stuck, why it gets stuck, common injuries associated with it, how to palpate it effectively, and lastly, how to treat it effectively. For those of you that don't know me, my name is Dr. Matt Maggio. I am a soft tissue injury treatment expert, specifically for neck, shoulder, elbow, and wrist pain. My focus is on finding and fixing scar tissue and reducing inflammation from chronic injuries without the use of drugs, injections, or surgeries, which does lead to a significant increase in overall functioning and long-lasting pain relief. I'm also the creator of the PEAK method and the founder of the soft tissue revolution, where we teach self-employed and overworked massage therapists a better treatment system that will allow you to cut your treatment times by at least 50% so you can stay healthy, avoid the dreaded burnout, and help a hell of a lot more people get out of pain. So back at it for part 2 in our series. If you haven't watched part 1, go back and watch that. If you're watching this on YouTube, we'll link it up top. Anywhere else, LinkedIn, Facebook, anywhere else, we'll put it down in the comment sections below. It'll give some context about the overall presentations of nerve entrapments. But this week's training, I wanted to cover the greater occipital nerve. So what is the function of the greater occipital nerve? It is the largest of the 3 occipital nerves. There's 3 of them, and it got the name greater occipital nerve, which is why it is the largest. Basically what it is it is a sensory nerve that goes and innervates along the skin to the back of the scalp and on top of the head. So basically real low down there and then kind of up this whole back part of the head there. It gives sensation to that area. So where does it get stuck? So it's got a long path from where it goes. The first spot it does get stuck is in between the C2 and C3 spinal nerve, where it comes out back through the vertebrae in there. The nerves come out through the neck and then they get stuck in there. Then the next area gets caught, and I always mess this up when I say it, but I saw obliquus capitis inferior muscle. You know, those good old Latin people when they named anatomy. Basically, oblique is where it goes sideways. Capitis is attaches to the head. Inferior, it's below. There's also a superior oblique in there as well. So it kind of like wraps around that tinier muscle in the suboccipital muscles. It's not actually considered one of the ones of the suboccipital triangle. It's just below that. The next area it does get caught is in the semispinalis capitis. That's a little deeper. It's a really big muscle. It's kind of deep to the trap. So you got the trap on the superficial part. So you got like the skin, the superficial tissue, then the trap, then the semispinalis capitis. It kind of goes in there and pierces right through there. Then it goes up and can get caught in the superior nuchal line. If you don't know what the nuchal ligament, it's basically a ligament that goes from C7 all the way up to the base of the occiput. And all the muscles in the neck actually anchor there. And it's a big mechanoreceptor function, all sorts of stuff. The nuchal ligament, it can get caught in there as well. And then it can also get caught in between the trap and the SCM, like right at the higher point there where it attaches on the occiput. So there's a lot of places where the nerve can in fact get caught. So why does this nerve get caught? I covered this more in depth in the initial first training, but basically one way is just poor and sustained posture, you know, sitting, looking down at a device, working on a computer, pretty much like all of us over time. What happens is it puts constant tension and pressure on the muscles. The muscles don't get enough blood flow, don't get enough oxygen, creates a hypoxic environment. Body starts to lay down scar tissue. Scar tissue is like glue, makes the muscle less flexible, weaker. Over time, that scar tissue gets bigger and bigger, and eventually it gets caught to the nerve, causes issues. Another one is just injury and trauma. You see this a lot in like people that play football, maybe soccer, like a lot of that, whiplash injuries, car accidents, all that kind of stuff. And then I also see it in people that have had past surgeries in the neck, maybe brain surgery or cervical spine surgery, something like that. They can go in and actually nick and cut a little bit of that nerve in there and can mess up some of the sensation behind the back of the head and into the scalp. So some common injuries associated with an entrapment. First one, occipital neuralgia. I hate these type of diagnoses. They don't really tell us anything. They just kind of throw some stuff in there. Usually whenever you see something with this, with like a GIA at the end and very broad, like the occiput, like it doesn't really tell us anything. Same thing with like itis or anything like that. It's just junk box for they don't really have a clue. There's like, okay, there's some pain in the head. Okay, that doesn't really tell me much. We always want to have what's called a tissue specific diagnosis about what's going on, because if we don't know what a problem is in the first place, we sure as hell can't fix it. Another one could be migraine headaches. Migraine clients are really difficult. They're tough to work with. And one of the key classifications that I make when I'm working with a migraine client, I like to ask them before they get a migraine, do they actually get neck pain before that? And if they do say that, then I know that soft tissue work and what I'm going to be able to do is going to be able to help. If they say no, it just comes out of nowhere. There could be so many other factors in there. It could be their hormonal cycle, could just be dehydration, could be a lot of things that aren't soft tissue related. So when I'm looking at a migraine client, I want to see that they get neck pain first and then they get the migraine. Lets me know there's things that I can do and go and help. Another one is just that tight upper traps. Basically what happens is when the nerves are caught up top, those upper traps are going to tighten up around there to protect the nerve, because the nerve doesn't want to get loaded up. It's your body's way. It's called protective tension, to try to take some of the pressure off of the nerves, because if the nerves don't work, you don't work. We cover this in depth a lot in the first training of this series. Next one's cluster headaches. Another one of those things where doesn't really tell us anything, but it's been associated with this entrapment of the nerve as well. Just like, oh, cluster headaches, it's clustered. I don't know what it really means, but basically some type of headache. But once again, I always want to look and see that I've had history of trauma up there, maybe bad postures, and then also they do get neck pain before they get any type of these headaches. And then the last one is just cervical disc degeneration. Degeneration, just a general term that the disc in the joint wears out. That happens over time. So basically what happens is, as the scar tissue forms in the muscle, eventually it compromises the nerve. Then all the muscles tighten up. They cannot protect the disc in the joint, puts more pressure in there. Then the disc starts to get degenerated and causes problems. And it starts with a bulge, and then eventually it becomes a herniation. How to find it? I always say, if you can't find it, you can't fix it. Your palpation needs to be very precise, very focused. So essentially what happens is when there is a nerve entrapment going on, the nerve doesn't have a lot of movement to it. I talked about this in the first training. Nerves have about 15% of extra slack to keep them healthy and make their way through muscles, and the greater occipital nerve goes through a lot of areas. So it has to have some slack in there. And what happens is when that slack is getting used up because it's stuck there in the scar tissue, the nerve doesn't move how it should. You should be able to get on both sides of the nerve and kind of bow it from side to side. When you can't, that lets me know that there is possibly an entrapment there. Another thing is all the muscles around that area are going to be like extra tight and hypertonic. And a lot of people are like, oh, there's a trigger points. No, it's not trigger points. It's protective tension by the muscle to take the pressure off of that nerve, because it doesn't want the nerve to get affected anymore. So the best way that I like to palpate this is I have the client sit in a chair with a good back, and then I have them go and I have them tuck their chin and drop that in, like a side drop in there. That really allows to get some of that upper trap in that semispinalis to slacken a little bit, so I can feel in there a little bit deeper and feel that. Because a lot of times if you just palpate it without that, where they're maybe laying face down or even laying supine, you're not going to be able to feel all that tension and know right exactly where it is. Next thing is just use bony landmarks like the base of the occiput and then C2. Then you know that it lives somewhere in there. That's how I got to do a lot of my palpation, is finding big things that you're comfortable with finding. That's going to let you know that you're right there where it needs to be. Our favorite part, how to effectively treat it. Here's the thing, you have to unlayer it first. So like I said, there's layers that go into it. And one of the layers that you have to go through first is just the nuchal ligament. And the nuchal ligament is very important to treat. So what I want to link up first is just a demonstration of me doing a little bit of work with the nuchal ligament, how we go in there and break that down. Because if we can get that tension off the nuchal ligament, then we can start getting into the trap in the semispinalis capitis. So I'll link that one right now. Link in, back off, pull some of that. And what you're trying to find is where that area of grit and tension is. That's usually where that scar tissue is. And you can see each time I'm pulling through, as I open that up, that allows that to open up. Bias my body over like that and pull up just like that. And if I want to get the other side, I'm going to come over just like that as well and pull up there. And what I'm feeling for is those areas of grit. Each time that I move it, I'm going to drop that head a little bit more, but I'm being very cautious to make sure I support the head and going like that. If we're going to get the lateral part over here, we're going to bias our body over just like that. And if we're going to get this medial side towards me, we're going to bias like that. Next thing we need to do is we need to free up the trap and the semispinalis capitis, because remember, it pierces through the semispinalis capitis and then sits underneath the trap. So we need to do that with manual treatment. And the way that I treat this is I have the client actually supine, and then it slackens the muscle. What I want to show next is an effective demonstration of us treating that area from one of our training courses. So I'm going to link that up right now. And when this area is dysfunctional, it can cause a lot of problems in there. But you don't want to go too far. You go to maybe about C3 is the furthest you want to go. Get some of that extension to open it up, and then you're going to pull that tension straight up. That's going to help that open up. And what can happen, at the base of the occiput from C1 down to C2 is there's some nerves called the greater occipital nerves. They can get stuck to the deep suboccipital muscles. They can get caught through the upper trap. They can get caught in a lot of different areas. And if you can get in there and get some of that tension, it's going to allow this to help to glide a little bit better. And that's going to open that up. You're going to go down and find about C2, C3. And where you're going to go in there is you're going to sink just like that. And then that's going to get your depth as you open up. And then you're going to pull tension straight up. And with this one, you're not going to stand up. You're just going to pull that. And you're going to lean back and pull that through as you go right up to the base of the occiput. So in the video, I talked about this idea of external slide. And basically what happens with external slide is you set it and then the motion goes and you have to go with it. A lot of treatments, internal slide, where you just set it and it kind of comes to you. That's the majority of manual treatment, especially myofascial release. But with this one, you have to do a little bit opposite, which is that external slide. So the way that I like to treat this is you're still going to treat it the same way for the trap going to semispinalis, going back to the greater occipital nerve. It's just going to be a difference in how much slack you get in the head and how much pressure you get. So the deeper you go, the more pressure you have to get and the more you have to drive in. You can see there how I use my body, I use my leverage to really get in there, because the treatment needs to be slow, deliberate, and focused. And lastly, you really only need to do about 3 to 5 treatment passes per area that you find that palpable nerve entrapment, because nerves do not want a lot of treatment. A lot of people will just go in there and beat the hell out of it, and actually makes the problem a lot worse. So 3 to 5 passes, but make them perfect passes as you go every time. I always say treatment is like a medication. You can do enough to be effective, but you can actually do too much and make it a lot worse. And when we're dealing with nerves, headache patients, migraine patients, we want to go real slow, real deliberate, and make sure we get the dosage just right. So that's all I got for the video. If you want to pay it forward and help spread the word, a couple things you can do is you can share some insights in the comment sections wherever you're consuming this, or any new epiphanies you might have. You might be like, hey, I never even realized nerve entrapments were a big deal. Well, there they are, and now you're learning. Another thing you can do is just share this with other providers out there looking to do excellent work and want to get on the path to actually solving problems and not just providing a basic service. Another thing is you can download and access our free training modules. I believe they are better, and a lot of people have told me they're better than most paid courses that you see out there on the internet. And lastly, you can reach out only after you go through all the free training to see if any of our in-depth training courses will be worth investing in. Appreciate you guys watching this one, and we will see you on the next one.